When an American opens a hospital bill for surgery and sees a total of $20,000 or $40,000, it rarely feels real at first. It's a number so large that it almost seems theoretical, disconnected from the flesh and blood experience of walking into an operating room, lying under bright surgical lights, hearing the muffled voices of nurses, and waking groggy with a patched-up limb or repaired organ. That number, though, carries the weight of an entire system, an ecosystem built on layers of fees, reimbursements, markups, shortages, and policy decisions stretching back decades. It's a system that Americans confront not in theory, but in bills they must somehow pay. Bills that shape their futures, their savings, their stress levels, their decisions about whether to get care again. So imagine this. You go in for a surgery that your doctor told you was routine. Maybe you broke your elbow slipping on ice, or you need a gallbladder removal. You might think the cost will be manageable. After all, you have insurance. Weeks later or months later, the envelope arrives. You open it and see that, before insurance adjustments, the hospital billed roughly $20,000. Even after adjustments, your out-of-pocket share seems absurdly high. You try to make sense of the line items: facility fees, surgeon fees, anesthesia, supplies, recovery room charges, pharmacy costs, imaging, and sometimes mysterious codes with no description at all. You call the billing office. You wait on hold. You feel the churn of frustration building as you wonder how on earth one short surgery can generate costs that rival the price of a used car. To understand what you're really paying for, you have to zoom out, not into conspiracy, not into cynicism, but into the unglamorous reality of American healthcare financing. Surgery is not expensive because one surgeon wants a raise, or because one hospital wants to pad its profits. It's expensive because of how every piece of the system fits together. Labor costs, supply chain volatility, reimbursement gaps, administrative bloat, insurance negotiations, government policies, and the complicated choreography of a surgical event that requires dozens of people and countless moving parts. If you could stand invisibly in a hospital corridor and follow the money, you'd see something surprising. Most of the cost of surgery is not the surgeon at all. The surgeon may bill a few $1,000s, depending on the procedure. The anesthesiologist adds their own fee, perhaps in the hundreds or low thousands. But the actual lion's share of the cost, the part that balloons your bill into the $20,000 range, comes from everything around the surgery: the environment, the equipment, the infrastructure, the people, the administrative machine. Consider the operating room itself. It's one of the most resource-intensive environments in modern society. It runs on highly specialized equipment, sterilization protocols, ventilation systems, monitors, surgical instruments, implantable devices, and a rotating staff of experts. Everything inside it must be cleaned, maintained, replaced, or upgraded according to strict standards. The cost of maintaining just one OR can run thousands of dollars per hour, even when no patient is inside. When the OR is in use, those costs become visible in what's called the facility fee, a term that many Americans have seen on their bills but rarely understand. A facility fee is essentially the hospital's charge for providing the setting in which care takes place. If you had the exact same surgery in a surgeon's independent office, if that were even possible, the cost could be a fraction of what a hospital charges. Large hospital systems charge these fees because they can, because insurers often pay them, and because they rely on them to offset losses from other parts of the system. Some of those losses come from caring for patients insured by Medicare or Medicaid. These programs are vital, life-saving, and widely supported, but they often reimburse hospitals at less than the cost of providing care. So hospitals shift the difference onto private insurance and, in some cases, directly onto patients. The numbers aren't tiny. When hospitals are paid around 80 cents for every dollar of cost from public insurers, they must recover that shortfall somewhere. That somewhere often becomes the facility fee you see on your bill. Then there's the matter of labor. A modern hospital is one of the most labor-dependent environments in the economy. Highly trained nurses, surgical technologists, anesthetists, support staff, cleaning staff, administrative teams, billing clerks, coders, and managers all contribute to your surgical experience. Labor costs have been rising for years due to shortages, burnout, and the sheer demand for expertise. Many hospitals spend more than half of their total operating budget on labor alone. When you pay for surgery, you pay for that entire workforce, not just your surgeon, but the people who sterilize instruments, process claims, stock supplies, transport patients, monitor vitals, and document every detail needed for regulatory compliance. And compliance matters enormously. Hospitals must maintain mountains of documentation to satisfy insurers, regulators, auditors, and quality control agencies. This creates administrative overhead, another invisible cost. Billing and insurance management alone can cost hospitals billions of dollars collectively. Every surgery requires authorization, coding, billing review, post-claim audits, appeals, and reprocessing. Every step adds administrative labor, software costs, or consultant fees. None of these are medical in the sense of healing a patient, but they are the infrastructure that enables hospitals to function in a regulated, multi-payer system. So where does that leave the average American patient? Often confused, often angry, often feeling betrayed by a system they thought was supposed to protect them. Add supply chain pressures to the mix, and the picture becomes even more complicated. Many medical devices, from implants to surgical screws to robotic surgical tools, are imported. When tariffs or shortages hit these imports, hospitals pay more for the supplies. Those increased costs eventually show up in the price of surgery. The implant the surgeon places in your knee or elbow is not a commodity like a kitchen screw. It may be patented, highly regulated, and manufactured through processes that don't scale easily. Hospitals don't buy a few dozen of them. They buy hundreds, sometimes thousands, planning for emergencies, inventory requirements, and vendor contracts that require them to stock certain devices. Manufacturers know that their devices are essential. They price accordingly. Then there's inflation. Over the last few years, inflation rose faster than many hospital reimbursement updates, meaning hospitals saw their costs rising faster than their revenue. Even a few percentage points can create strain when the institution is already running on thin margins. And many hospitals are operating on thin margins, especially independent rural hospitals or small community hospitals. Some have closed their surgical departments entirely. Some have shut down for good. When those closures occur, the remaining hospitals must absorb more patients, more volume, and higher complexity. That too factors into cost. And then, in a stroke of irony, the very attempts to fix the system, like requiring price transparency, often reveal just how chaotic the pricing is. Hospitals must now publish machine-readable files detailing their prices for hundreds of services. Yet many Americans have never seen these tools, never understood how to read them, or discovered that the posted prices don't match what they are ultimately charged. Some hospitals comply only partially. Others post data without user-friendly formats. The average patient, trying to shop for surgery the way they might shop for a car, quickly realizes something. Healthcare does not behave like a normal market. You don't always know the exact procedure you'll need. You don't know whether complications will occur. You don't choose which anesthesiologist is on call. You rarely get a firm price up front. And even if you do, coding differences after the surgery may alter the final cost. This is where protections like the No Surprises Act come into play. This law was meant to shield patients from out-of-network charges they didn't choose, particularly for things like anesthesia or radiology. And it has helped. Many Americans are now protected from the most egregious surprise billing scenarios. But the law does not and cannot solve the fundamental challenge, the total price of care. A surgery that costs $20,000 to the insurer may still cost you thousands out of pocket if you have a deductible, co-insurance, or out-of-network component. And if you're uninsured, the law doesn't cap what a hospital can charge. Hospitals may offer discounts, but those discounts vary widely. Americans have become experts at navigating phone trees, asking for itemized bills, requesting financial assistance, negotiating charges, appealing denials, and setting up payment plans. This is not the expertise anyone wants. No one dreams of becoming proficient in deciphering billing codes or arguing with insurance representatives. But many Americans must do exactly that to protect themselves. Consider the person who receives a $20,000 bill for surgery. Maybe they struggle to pay it. Maybe they start cutting corners, avoiding follow-up visits, skipping medication refills, or working through recovery because they can't afford more time off. Maybe they go into medical debt. Maybe the debt is sent to collections. Maybe their credit score drops. Maybe they feel ashamed. But they shouldn't, because the system isn't built to be simple or affordable for ordinary people. It's built on patchwork solutions and financial compensations that shift costs like a shell game. To someone outside the system, a $20,000 surgery bill looks like an overcharge. To someone inside the system, it often looks like the minimum needed to keep the hospital running. Both perspectives are true, and that's the uniquely American tragedy. The cost of surgery is not simply the cost of medical care, it's the cost of an entire system built on compromise. If the average American could see behind the curtain, they might have more compassion for hospitals, and also more outrage. Hospitals are not getting rich from $20,000 surgeries. Many of them are struggling to break even. Yet patients are also suffering financially because the pricing structure falls hardest on them. There are, however, glimmers of hope. Patients who understand their rights can avoid some of the worst surprises. Anyone can request a good faith estimate before a non-emergency procedure. Anyone can ask for an itemized bill and challenge incorrect charges. Anyone can negotiate. And many succeed. Advocacy organizations, patient navigators, and even some hospital billing departments are increasingly responsive to patients who ask thoughtful questions. Transparency tools, though imperfect, are expanding. And ongoing national conversations about healthcare reform continue to pressure insurers, hospitals, and policymakers to simplify the system. But until that reform arrives, and it may take years, Americans will continue to face $20,000 bills that strain their budgets and test their patience. The best armor is knowledge, knowing where your money goes, knowing what you are and aren't responsible for, knowing how to negotiate, knowing your legal protections, knowing what questions to ask, and knowing that you are not alone in navigating the labyrinth. A surgery bill may be $20,000 on paper, but the true cost is the complexity behind it: the staff, the equipment, the regulatory burden, the supply chain, the negotiations, the overhead, the shortages, the policy decisions, the opaque pricing, the financial losses absorbed elsewhere. And understanding that complexity gives you power. It may not lower the bill instantly, it may not solve every problem. But it shifts the dynamic. It turns you from a confused recipient of a cryptic invoice into an informed participant in your own care. someone who can push back, question, negotiate, and advocate. In the end, the story of the $20,000 surgery bill is not just about numbers. It's about the lived experiences of millions of Americans who face these bills with fear, frustration, or disbelief. It's about a system that has grown so intricate that even insiders struggle to explain it. And it's about the need for collective understanding. Not blame, not despair, but clarity. Because once you understand what you're really paying for, you're better equipped to push for change, not just for yourself, but for the country.